This conference will now be recorded.
Early pregnancy care test 1. So we are going to answer the SBAs. So the first question is that incidence of clinically recognized miscarriage in pregnancy is about how much? Clinical incidence of miscarriage?
10 to 20%?
Yeah, the answer is 10 to 20% because this much pregnancies they tend to end in miscarriage. That is the problem. Okay, so here the answer is D, 10 to 20%. Okay. Then question number 2 is the most common indication for women attending gynecology emergency in the UK is A, bleeding. Yeah, so what is the most common cause? You can see here also.
Answer is A, bleeding in early pregnancy, I think.
Yeah, the answer is A because there will be bleeding in early pregnancy, and that is the most common cause of ER visits during pregnancy. Then I have a question for you that even for these things, like when you have a non-pregnant patient, still the most common cause of ER visits will be bleeding. Most of the patients, they will always come for the bleeding. That is the point. Okay? So even in pregnancy, outside pregnancy, most common complaint will be bleeding, and then will be pain in the second trimester. And the women, they will always come with bleeding, or then majority of them with bleeding, and then they will come with the complaint of pain. Okay. So the question 3 reads, which of the following routes of administration is inappropriate for the drug misoprostol? So misoprostol, first of all, what sort of drug is this one? What do you think?
Prostaglandin E1?
E1. So can you give it in the
Subdermal.
No subdermal.
It's
yeah,
not given.
that is yeah. Subdermal. It
Answer
is never given subdermal.
B.
That is the correct
Subdermal
answer.
B.
Yeah. So I have a question for you. When you say that this is E1 analog, so do you think that we can give them this drug we can give to the asthmatics? Can we give it? If you have someone who is an asthmatic lady, so can you give them misoprostol? What do you think?
F2 alpha is contraindicated.
Yeah.
E1 is
Okay.
we can.
Yeah, E1 is fine.
E1, E2 is okay.
Yeah, you can give E1 because it has no effect on the bronchial, this alveoli. So it will not cause bronchoconstriction. So that's why it should not be. It can be given easily. But who should not be getting prostaglandin F2 alpha, dinoprost? The one who is asthmatic. Okay, don't give carboprost or dinoprost to the patients to the ladies who have history of bronchial asthma or reactive airway disease. So tell me about prostin. This is prostaglandin E2. Prostaglandin E2, can you give it to the...
Yes, we can give it to the asthmatics. It doesn't have any reaction towards the bronchioles.
That is okay. So it can be given. So that is it. That we can always give it to the pregnant patients who need it. And what else can they ask you? That which route is better? Or do you think the vaginal or the oral?
Sublingual.
Why sublingual is better?
Because it has got the highest absorption from the sublingual route.
Quickest absorption time.
So if you have to choose between the oral and the vaginal, is there any difference?
Then vaginal. If we will give it to the oral, so it has to pass to the first pass metabolism.
Yeah.
And it also causes the gastrointestinal effects and fever. Whereas in vaginal, so it doesn't have to go through the first pass, so it will be having more absorption
Yes.
from this route.
Yeah, that is one of the facts. And then the second thing is that for the action of the misoprostol, it is known that we need a sustained level of misoprostol. It is not if you will give them orally, or you will give them like if you are giving them orally, then the levels may fluctuate. Initially they will be high, and then as the metabolism will increase, so the active bioavailability will decrease, the active drug, its level will decrease, so that's why we will not get a sustained action. So for a good action, we need a sustained level of the drug. So like they should be, after 2 half-lives, the level of the drug should be fine to do the process. Okay, that is the point. So vaginal and oral, they are equally effective. Sublingual is more effective, but we have more experience of giving it orally or the vaginal, so we will include the patient into his selection, and then both routes can be used. But we never give it subdermal, or we never give it subcutaneously. Okay. So the question 4 is, so here that for the question 3, the right answer is B. We don't give in the derma. Question number 4, which one of the following ultrasound descriptions is diagnostic of miscarriage? Like gestational sac, CRL, crown rump length, fetal heart rate. So all of these features, they can be combined. So look at the 5 options. So which one do you think goes with the answer? Because they have combined the all options, and otherwise also you will not decide just on the basis of the sac diameter. You will have to take all at least 2 measurements should be there. Like we don't consider this yolk sac, but if the yolk sac is there, it's a good sign if you can see. And because usually it will be visible, you can see that. But for its presence or absence, it is not required for making a diagnosis of the miscarriage. Depends upon the size of the sac and the size of the fetal pole. So here are 5 options in front of you. So which one do you think is correct?
Option A, mean gestational sac diameter 25 mm with no
With
obvious
no
yolk.
obvious.
Option A.
Option A. So it is fetal pole, but you didn't see any fetal pole. So what about this one? That here was the diameter was 40 and the CRL was that will be a viable pregnancy. Yes. So
Yes,
is the
because
correct
fetal
For the
heart.
evidence, fetal heart.
Yeah. Yes. So that will be
Yes.
the fetal heart. That is the point. Okay. Let's go to the next question. So a 20-year-old who is at 12 weeks gestation, she has a 2-day history of vaginal bleeding and lower abdominal pain. Ultrasound shows a 25 millimeter fetal pole with absent fetal heart rate. Pelvic examination reveals her cervix to be 4 centimeter dilated with bulging intact membranes. So which of the following is the most likely diagnosis in this case?
Option C, inevitable miscarriage.
Yeah, C.
C. Yeah, C is the correct answer because already this patient is way dilated and it is already 4 centimeters, so she is most likely to miscarry that pregnancy. So the correct answer for question number 5 is C. Sometimes the questions can be over simple. So then in that case, you don't doubt yourself because they're just testing your concepts. So you don't have to be upset that why this question is so simple. There can be simple questions, and especially for the SBAs, the things can be simple. Like they will ask you about the incidences, they will ask you about other problems, that what are the incidences, stuff like that. So it's okay. It's totally okay. It's not essential that the question should be very tough. Okay? That is the point. Okay, so the question number 6 says 29-year-old who is 6 weeks in gestation is diagnosed to have right tubal ectopic pregnancy by transvaginal pelvic ultrasound. Which one of the following factors would enable systematic methotrexate to be offered as a medical treatment option for the ectopic pregnancy? Because you have certain criteria. On the basis of that, you can give
B.
treatment. Okay, so the B is. So let's go over the
Yes,
options one by
option B.
one. Yeah, B is the correct option. Why option A is wrong?
Because for methotrexate, the initial max size should be less than 3 cm.
Yeah, 3 cm. Yeah, because why I've asked you this question, because in the GTG it was that 3.5, but in the new NICE guideline it is 3 centimeter. Then fetal heart activity is a clear-cut contraindication, and then ultrasound evidence of hemperitoneum, no, it has no significance. And previous self-injectomy also, no, we won't do that. I shared some questions from the essay from the strategy with you, in which they said that you should not consider this fact, right? So just give her the treatment and she's going to be fine. So here for the initial medical treatment, better chance of success if the initial serum level is 1500. By the way, up to what level of serum beta-hCG you can give methotrexate?
1,000.
5,000.
Yeah, up to
5,000.
5,000. Yes, you can give her.
Yes.
And it is better that if the level is between 1500 to 3000, then the best results, but up to 5000 you can give it safely. For your interest, in the American College of OB/GYN, I read one article like it was 6-7 years ago. In one case they gave up to 10,000 where the serum beta-hCG was 10,000 international units. Then again they treated that with 2 doses of methotrexate. So the things are possible, but we have to follow the college guidelines. And then I hope you remember that methotrexate is not the only treatment for the medical management of ectopic pregnancy. We can give a number of substances. Then the question is that why do we give methotrexate? Because we have more experience of dealing with this drug and the side effects. So anytime in the exam or in your practice, whenever you tell your patient that I'm going to give you this drug, you are supposed to tell them about the side effects, complications, and failure rates, how they should take, what precautions should be given, should be taken. Like if she's taking, like if you're giving tetracycline to some patient, then you should know that you should not. So you should know that you will tell your patient not to take it with antacids, or she should not take milk because it will impair absorption, right? That is the point. Then some of the drugs you have to take on empty stomach, and some of the drugs you are supposed to take after food. So if you will give methotrexate to your patient, what information you would like to give her? What can happen to her? What do you think?
Pain is the side
What is the
effect.
most common side effect of methotrexate?
Gastrointestinal, nausea,
Yeah,
and
Stomatitis.
pain, stomatitis. It
pain.
can cause inflammation of any area, but you can tell your patient that pain is the most common complication. Okay. Then you will tell your patient that it can be given as a first line treatment to the women who are unable to return for follow-up and who have all of the following, like they don't have any significant pain, they don't have and they should not be in pain, and the pregnancy should be intact. Because if the pregnancy has already ruptured, then it merits surgical treatment. Okay. And then the adnexal mass, it should be ideally smaller than 3 centimeter or 30 millimeter, and there should be no fetal heartbeat. And serum beta-hCG level should be less than 1500 international units. This is preferable, but up to 5000 you can give it. And there should be no intrauterine pregnancy. You must have seen or read about the cases where the woman was carrying a ectopic pregnancy and it was not taken into consideration, or sometimes, even in the early pregnancy, sometimes you can think that this is a pseudo sac. So then they can make a mistake, because anywhere, whenever a woman is pregnant, you know that Arias-Tallis reaction will take place. There can be proliferation of the endometrium. There can be a pseudo sac in the uterine cavity. Okay, So then you have to take care. The diagnosis should be by some expert, and it is given on the methotrexate is administered on the orders of a consultant. Okay? And just to avoid killing a normal pregnancy. Okay? Because even if the pregnancy is in the tube, there is plenty of HCG, and the endometrium, it is going to show the changes, so which are consistent with pregnancy. So you will give them methotrexate, and you will tell them about the side effects. If the patient's compliance is good, she can go home and she can come back if she develops any problem, or she should return after 48 hours for the repeat serum beta-hCG, and it should fall by at least 15%. If it doesn't, then again we will not administer the second dose right now. You will give her some time, because at this time it may rise because of the release from the cells, because yesterday we said that HCG will come from the sensitive trophoblast, so this problem can occur. So then you will do on day 7, and there should be a fall by 15 to 66%, but now they say that even 50% overall fall is good. And then you are going to repeat the serum beta-hCG on weekly basis till it reaches to less than 20 millimeters of 20 international units. Then you can discharge your patient. And you need to tell your patient that she should not take aspirin, and she should avoid becoming pregnant for 3 months, because 12 weeks is the washout period for methotrexate. So remember all of these things, because they can ask you any question from anywhere. So if you remember, like we read before, that if the serum beta-hCG level is up to 1000, you can or less than 1000, you can offer expectant management also. But in the question, they categorically they have asked you about the medical treatment. So that's why we are telling them that at which level we can give serum beta-hCG. Then you must have seen another question in the SBAs or maybe in the recalls. Which factor is associated with the highest chance of failure of the methotrexate or the medical treatment of the pregnancy?
Fetal heart rate.
Rate is there. Yeah, because that is actively dividing tissue, right? That is the point. So it will cause failure of the treatment. What will happen? Like the size of the baby will decrease, and most likely this pregnancy will end up in miscarriage, but after a gap of like 4 to 6 weeks. It will not occur immediately. Pregnancy will continue, but the baby will have severe IUGR, and then the baby will die later. My references, and I have seen it in the studies. Okay, let's go to question number 7. A 29-year-old who is at 6 weeks gestation presents with slight vaginal spotting. Transvaginal pelvic ultrasound shows no evidence of any intrauterine or extrauterine pregnancy. A serum beta-hCG is measured at initial presentation and repeated 48 hours later. Which one of the following beta-hCG results is suspicious of a clinically significant ectopic pregnancy?
Option E,
D.
2000.
D.
Option E.
So why not
No,
E?
option D. Correct answer is option E, because in D, beta-hCG is 3000. It is increasing.
It is increasing, and it is increasing like how many times?
Yes,
Like
this is
3
More
times,
than
right?
66.
yes, 3 times.
So
6%.
yeah. So when you will suspect that this is an ectopic pregnancy, when the rise in the beta-hCG is inappropriate, right? This option D, it will
Would be
go
low.
towards a normal pregnancy, right? So E
Yeah.
is the correct answer. That is the point.
Yes.
So as you know that serial measurement of the serum beta-hCG is very helpful. Why it is so? Because it is reliable, and it is especially useful in the diagnosis of asymptomatic pregnancy. Because if the patient has sought your attention, then she's going to be fine. But if she is asymptomatic and this is accidental diagnosis, then you can have problem with the diagnosis. You can be double-minded. You must have seen that every time we are seeing the patients with ectopic pregnancy, we are not deciding on the basis of the first test, because there can be several variations, right? So that's why we give the patient time, and before you make any diagnosis, you should see at least 2 levels. Okay. So in the ectopic pregnancy, as you know, if the level is between is up to 1500 or more, then it can be identified on the transvaginal scan. And once it is 3000, then you should be able to see the sac on ultrasound, abdominal ultrasound. Okay. And usually, you know, the rise is inappropriate. So this 2000 to 2500, it will be a better answer, because D is compatible with the normal pregnancy. That is the reason. 500 to 1200, it means that it is increasing, and it has increased by more than 100%. Then 800 to 200, maybe she is miscarrying. Similarly, C, it shows a picture of miscarriage, because if it is automatically dropping, then you don't have to give any treatment. You are just going to observe her. But if you become symptomatic at any time, then you will have to go and manage it. Okay, question number 8. A patient with a positive pregnancy test and a small amount of PV bleeding and no abdominal pain presents with a single transvaginal ultrasound scan showing an intrauterine gestational sac with a crown rump length of 5 mm with no fetal heartbeat. So which of the following would be the most appropriate management plan? So before proceeding to the management, tell me that what exactly do you get from this information? And when you can see the fetal heartbeat, when the CRL is 2 mm, even then you can see cardiac pulsations, cardiac activity.
C.
Option
Yes.
C, yes.
C.
So why you will say C?
Because CRL is less than
CRL is
7
5
millimeters.
can
And you
be-
see the
yes.
intrauterine gestational sac, and there might be discrepancy in the LMP. She might be giving the wrong, or there might be, the wrong calculation. So to be definite, you have to repeat the scan before you diagnose her for miscarriage.
Yeah.
If the CRL was 7 millimeter, then you will call your other colleague to confirm if there is no fetal heart rate, and then still you call her back in 7 to 10 days time for repeat scan.
Yes.
Yeah. And your patient is stable, no immediate concern. Okay.
Yeah.
So if you are sometimes, you can have 2 good answers and you will be double-minded. In that case, you should think that the patient is in your clinic or she's in your ER, and now you need to decide immediately that what exactly is happening here. So that's why, because these questions, they are based on the real life cases. Okay? And because they want you to solve problems of the patients who are coming to you. So they are very realistic. So what you have to do, just answer whatever you will do in your daily practice. Yeah, C is the correct answer, because we cannot diagnose anything until the baby is less than, the baby has attained a size of 7 millimeter or more. And here your patient is stable. And you have just done a single TVS. So don't decide on the basis of just one CS. So if you will scan this patient after 2 days or 3 days, or rescan in 2 days, it is not going to be helpful. And we are not going to do anything else. And since this is a viable pregnancy, so we don't have to do the testing in 3 weeks. When will you think about repeating serum Beta-hCG after 3 weeks?
If you don't see any intrauterine gestation
After
sac,
expectant management.
yeah.
And tell me about any other condition where you will have to carry out a pregnancy test
If
after
she
3
has
weeks.
a history of previous gestational trophoblastic or molar pregnancy, then after every event of pregnancy, you have to repeat Beta-hCG in 3 weeks time.
Yes.
So if a patient comes to you for emergency contraception, you will not do this test after 3 weeks.
Oh yeah.
Patient came to you. Yeah. Okay. So don't don't limit yourself to single topic. Okay. Whenever you
Yeah.
are thinking about a test, think about all possible scenarios. Okay. That is the point. So patient comes to you for emergency contraception, you have offered her something, some medical treatment, and then you have sent her back, then you should call her back or ask her to go for the urine pregnancy test, and then you can say that there is a pregnancy or everything is fine. Okay, so question number 9. A 25-year-old woman presents to the A&E department with left iliac fossa pain, vaginal bleeding, and a positive pregnancy test. So, which symptoms may be associated with an ectopic pregnancy?
Option A, passage of
E.
tissue.
All.
All. Passage of tissue, that will go in
All
favor
of them.
of
On the molar pregnancy.
incomplete or complete miscarriage,
Incomplete.
right?
Yeah.
So you, yeah,
Option E. Okay.
yes. So patient is going to present with all of these symptoms, and in addition to the, because here we can give only 5 options, okay? But your patient can have symptoms like torsion, ovarian torsion, like appendicitis, right? Or she can have diffuse abdominal pain. So characteristics of the pain they can change. So all of these symptoms can be the presenting complaints. Question number 10. A 25-year-old woman presents to the A&E department with abdominal pain and a positive pregnancy test. And she's at 8 weeks. Ultrasound is performed to rule out a miscarriage. Ultrasound scan shows an intrauterine gestation sac with the ratio of transverse to anteroposterior dimension greater than 1.5 with cystic spaces in the placenta. So what is the likely ultrasonographic diagnosis?
Partial mole.
Yeah, this is partial. Why we will say that it's a partial mole?
Ultrasound findings.
No, because
Number
the
one.
placental finding is spaces. In complete mole, there will be no placenta.
This is the ratio of transfer to an anteroposterior dimension greater than 1.5.
Yeah.
And
So,
with cystic space. So
you know
ultrasound findings.
these ratios you will find even in cases of delayed miscarriage also. You know why? It can occur due to hydropic changes, right? It can be there. And then also this dimension it will change. But when you will talk about the cystic spaces, then you can say
Placenta.
that this is associated with changes in the placenta, because both of these are soft markers of partial molar pregnancy. But you should keep in mind that in cases of delayed miscarriage, you can get this ratio, okay? But in that case, you will not have these cystic spaces. In cases of miscarriage, you will find the swollen placenta. It can occur due to hydropic change. In that case, there will be hydropic change in the placenta. But if you see cystic changes and the ratio of the AP to the transverse, it is greater than 1.5, then you have to think about partial molar pregnancy. So D is the correct answer. So let's go to the question number 11. So read the question very carefully. The day before your exam, I have been doing this myself, like we used to hold the book, nothing will go into your mind, but you are feeling very happy that at least you are not wasting the time. The fact is that if you have been unable to do something in the previous 6 months, then what makes you think or believe that you can do in the last 6 hours? You can't do anything, right? So try to relax. Just look at the algorithms, just look at the important numbers, and you should be fine. And you should sleep well. Half of the time, what happens is that the candidates, they don't feel fresh, they are tired, they can't think, they can't concentrate, especially during the second paper. So in second paper, they're asking more and more questions. That is basically based on the obstetrics. And in obstetrics, the scenarios can be very lengthy. Even the SBAs, they can be very confusing. So, and then there are many gray areas in the obstetric management. Things can go this way or that way. So you have to make a decision. That's why it's very important to stay fresh. Your exam is quite challenging and it will take like 6 hours with 1 hour for the rest, but during that time you'll be eating or refreshing up. So these are the points, okay? So read the question very carefully. If you want to answer the questions in the right way, then you have to read them in detail. You should be able to dissect it, that what exactly they are asking you, because just by a couple of words, the scenario can change. Okay? So let's do the question number
Sorry.
11. Yeah, is there any
Sorry,
question?
Aisha. Yeah, just a little confusion here in
Yeah.
that question.
Okay.
What will make us say the partial mole? Why don't we say complete mole? Is complete mole there's going to be no placenta? Is that right?
Diameter, it can be the same, but usually in the complete molar pregnancy, you are not going to see the cystic spaces in the placenta.
All right.
That is the point. Okay?
Thank you very much.
No problem at all. So question number 11. Miss XY is a primary gravidae who presents to the A&E department with dark brown discharge PV for 1 day and mild lower abdominal discomfort. She is 7/40 pregnant as per her last menstrual period. Her TV scan shows the presence of a gestational sac and a yolk sac with a fetal pole of 7.5 millimeter and no fetal heart activity. So which of the following treatment options are best suited to her? Let's put all the options on the same page. So what should be done for this lady? Should we think about miscarriage, or should we rescan her in a week? Or should we do this serum Beta-hCG and then repeat that? Or should we go for serum progesterone? Or we should do serum progesterone to assess viability? I will go back to the case. So here you have a lady who is 7 weeks pregnant, primary gravid, fetal pole is 7.5, and no fetal heart activity. So this is 7.5.
Yeah. We'll rescan in 1 week time.
Option B, rescan in 1 week.
Yeah.
Yeah, you should give her
Yeah,
the
we
option,
can
okay? Rescan in
straight away.
1.
Yeah.
Because if your patient is bleeding or she has pain, you will obviously push her to the OR, okay? You will do that. But if the patient is fine, she is stable, then you should take a second opinion. So rescan in 1 week, or they added this 1 week just to confuse you, because there is, the sac is fine, but the CRL is more than 7 millimeter, no visible heartbeat. So maybe you have been unable to see that. We don't have mechanical eyes, right? So maybe our experience is not that good, or maybe someone else is more experienced. So there is no harm. We should take a second opinion. Always give benefit of doubt to your patient. Okay? Patient is stable. Had she been unstable, she would have gone to the OR. That is the rationale behind it. So you can repeat the scan, and you can do it now, or you can repeat it after 7 days. They didn't give you the option of carrying out the second scan now, so that's why you will assume that you can call her after 1 week. And whenever you are sending such patients home, you have to tell them that this is the emergency contact number. This person is responsible for your overall care. And if you develop any problem at any time, and this service is closed, because all daycare units, they will be closed after a certain time, after 5 p.m. Okay. So if you have any problem after the working hours, then you should have to go to the early pregnancy assessment unit. That is one point. Then the second point is if your patient has history of previous miscarriage or previous ectopic pregnancy, then you have to tell her that she has to go to the early pregnancy assessment unit. That is the right place for them, because those centers, they have more experienced persons, and they will be able to diagnose them in a better way, and more importantly, they will not misdiagnose anyone. That is important patient safety issue. And so in the questions also, they will ask you history of previous miscarriage, things are fine, and you want to tell her where she should go for follow-up, then you will sometimes you can be confused that if everything is fine, then why I should be sending her for follow-up. But the rationale behind it is that you want to decrease the incidence of misdiagnosis. So send them to someone who can provide care in a better way. Okay. So question number 12. Miss XY is PG who is 9 weeks pregnant and has confirmed diagnosis of missed miscarriage. like she had 2 TVS scans a week apart, so diagnosis has been confirmed. After discussion of the various options, she opts for medical management of the miscarriage. She is extremely anxious about the discomfort associated with the procedure, and she has a low pain threshold. So which of the following is appropriate for medical management of the miscarriage?
B. Misoprostol 800 microgram with NSAID.
So you will not like to give her mifepristone?
It says for early pregnancy, you don't
No, for miscarriage, we will not give.
miscarriage, you don't
For
give
miscarriage, we
misoprostol.
cannot use, will not use
Yes.
it.
Yes, for the missed
Option
and
B.
incomplete miscarriage,
Don't
if you
give
will follow the FICO guidelines, they say that you can give misoprostol 800 micrograms stat if your patient has missed miscarriage. And if you have diagnosed incomplete miscarriage, then you can give 600 micrograms misoprostol stat. And for the pain relief, you can give NSAIDs, like mostly brufen is given to the patients. So you don't have to go for other analgesics, just give them simple analgesia and give them misoprostol. No need for mifepristone. You will give mifepristone where the os is closed, or miscarriage is occurring in the second trimester, or it is occurring in the, or there is IUFP in the third trimester. But that too depends. If the os is open, then you don't have to give mifepristone. And in cases of missed miscarriage, why there is miscarriage? Because there must be some defect in the progesterone. So,
Yeah.
and this mifepristone, this is a selective progesterone receptor
Yeah. So basically, it
modulator.
should be given
So yeah, so no
in the
progesterone. So
patient.
you, yeah, go on, please.
It's an anti-progesterone, so we can give it in the patients having the termination of pregnancy, because we have to block the progesterone supply. So that's why we
Yes,
can give it.
yeah. So these are small points, like they seem simple, but they are simple only if you know the background and you understand the pathophysiology and the mode of action of the drug. So that is equally important for you. So in the normal pregnancy, when you are going to terminate it because of on some grounds, because they must be making some diagnosis and they will apply the miscarriage clause, right? Miscarriage act clause will be applied. So in that case, since you're dealing with a healthy pregnancy and there is more progesterone and some estrogen, so you are going to give anti-progesterones. Here the patient is miscarrying because originally they have some defect, so that's why we don't have to give them many drugs, just do the needful and manage her. So the correct answer is B. And then overall, for the pain, we can give them NSAIDs. And do you think she can have some other problem? And she will ever require any other drug? Can you think of something?
antacid.
Antacids we will not give because we are giving misoprostol. It can cause GIT symptoms. Your patient can have vomiting, so maybe you will have to give antiemetic.
Antiemetic.
If they give you a patient who has received good analgesia and this drug, and now she has, they ask you that what medicine are you anticipating to give her, that will be an antiemetic because it can cause GIT effects. That is it. I tell you people in each session that if you are studying every day for 4 hours, then for 2 hours you have to read the stuff, the guidelines, and just if you are making your own notes, just highlight the points and develop this habit of leaving the stuff. Don't have to read from cover to cover, just read the important points. And then in the second and the third reading, you should read just the main points. And 2 hours you need to spend on the MCQ books. There are so many good books, at least 2 books. Okay. Strategy, I gave you people this link. I hope that it is working, and I don't know at what time they will revoke it. So I would advise that go to the modules and take out the questions with the answers. You can put any answer and then download all of those questions. Okay. So that you will be able to access them at a later stage also. That is the point. So let's go to the and make the folders. topic wise, that this is what module number 1, module number 2. So, because this is your exam, so you have to, I'm going to be there to help you, but you have to make your personal effort also. So do it once or keep doing it several times. So better that you should
Dr. Aisha,
organize yourself. Yeah. Yes, dear.
these modules which you have made, these are you made it by yourself, or these are any given by RCOG? Any
These are given by
topics included
RCOG.
in each
RCOG. There are
RCOG?
11 modules, and
Okay.
if you will go to the RCOG website, you will find the folder on
Yes, I
syllabus.
tried to find it, but I did not find.
Okay, I will share the link in the group. Don't worry. I will show you that.
Okay.
They have made
Okay,
it
fine. Thank you.
they have made it simple, and you will see that how many topics are falling under one heading, one module. Lot of stuff is done. That is
Okay. Okay, fine. Thank you.
no problem. So question number 13. Okay, so the answer was rescan in 1 week. That was the answer. Let's go to question number 14. Miss XY is 9 weeks pregnant. She presents to the early pregnancy clinic with a history of painful vaginal heavy bleed. 96 hours ago, ultrasound reveals a live fetus at 9 weeks with a 5 by 5 centimeter subchorionic hematoma, and booking bloods reveal that she is A negative with no atypical antibodies. So which of the following treatment options are best suited to her with regard to administration of NTD? So she is at less than 12 weeks, but she has this heavy bleeding, painful heavy bleeding. So this is your proof. There was painful and heavy bleeding 96 hours ago, so she needs NTD. How much NTD? Yeah,
250.
it is. Yeah, so we are going to give her 250 international units. So C is the correct option here. Question number 15. A 25-year-old woman diagnosed with a complete mole at 16 weeks is scheduled to undergo surgical evacuation in theater, which is the only acceptable management plan in her case. So they have already mentioned that she is going for surgical evacuation. So then what are they expecting from her?
I think E will be the answer because you don't give cervical ripening or oxytocin for molar pregnancies.
For me, option A is better
Yeah, E.
because we already A cervical priming using prostaglandins,
You don't
because
give.
we already decided for surgery. So just before surgery, we can give for cervical dilatation.
And for molar pregnancy, we don't give cervical ripening and oxytocin anyway, for the risk of.
Not really too long, but just before surgery, we can give.
You can give her, but even if you will not give this something for priming, can you do this suction evacuation, or you can't?
For 16.
We can do such.
We can do, but just to facilitate the process.
Okay, so tell me that you are doing this suction evacuation and this patient starts having hemorrhage. What will you do?
Oxytocin for your life-threatening hemorrhage.
Yeah, so the correct option here is, this dilatation once your patient is sleeping. Sometimes, you don't have this misoprostol or other types of prostaglandins. In that case, what do? You will simply use the dilators, right? Up to a certain number till you can introduce the cannula. So that you can always do under GA. Even if you will not carry out this priming process, nothing serious will happen to the patient. But on the other hand, imagine if you're doing this, removing this molar tissue, you must have noticed that sometimes it will be associated with severe hemorrhage. Okay, I have seen people having hysterectomies done because of this uncontrollable hemorrhage, right? So the guideline says that if your patient is having heavy bleeding, then you can give, the consultant should be consulted and he should start oxytocin infusion. There is theoretical concern that if we will use this oxytocin, it can result in embolization of the moles. But that's a theoretic risk. On the other hand, if you will not control the bleeding, your patient can die due to hemorrhage. Actually, there are many reports of deaths after heavy bleeds due to molar pregnancy. So the correct option will be think about the serious thing that one, and because you need to protect your patient from that thing. Okay. So routine use is not allowed if the patient is not bleeding. No indication for oxytocin, starting oxytocin. So C is the correct answer, that oxytocin infusion in cases of life-threatening hemorrhage. That is the correct answer.
Okay.
Question number 16 says that which of the following statements is appropriate in women presenting with early pregnancy with bleeding? A, ACG measurement can determine the location of pregnancy. This is obviously false. It cannot. Then if on expectant management, pain and bleeding, they are resolved in 7 to 14 days, the uterine pregnancy should be repeated after 3 weeks. Yeah, this is good.
Yes,
But
yes.
still, yeah, that is correct. But we should go with the other options also. Mifepristone can be used in miscarriage and incomplete miscarriage. No, we don't do that.
No.
Surgery, 1 in 10 patients may need further treatment in the form of microception or surgery. No, it doesn't work like that. Serum progesterone measurement can be used as an adjunct to diagnose. We don't do that.
No.
So B is the correct answer.
B is.
So do we ever use this serum progesterone for any decision making in cases in context of early pregnancy complications? No, we don't.
We do not use it now.
Yeah, only in the clinical trials they can do that.
Yeah.
So how you will use the information of this serum progesterone in your practice? Like if the serum progesterone level is less than 20, what will it tell you?
Missed.
Unlikely the pregnancy is going to be ongoing, because like it has to be at least more than 30, I think.
Yeah, less than 20 or 20, it means that patient is already miscarrying. And then if it is between 20 to 60, then these such pregnancies then are associated with poor outcome, but they can go either way, but we anticipate that the outcome will be poor. But if it is progesterone level is more than 60 nanograms, so that is nanograms or micrograms? Micrograms. So then that is reassuring that your patient has a viable pregnancy. Okay. Question number 17, medical management for an ectopic pregnancy can be considered if unruptured ectopic pregnancy of less than 45 millimeter, or cardiac activity is demonstrable, or HCG is less than 3,500 international units per ml, there is abdominal pain, or there is no evidence of intrauterine pregnancy.
C.
Why not A?
Option E. There is no evidence of intrauterine pregnancy.
Yeah, E, because this is they're saying less than 45, but how much less than 45 we don't know. Okay? Because usually you will give up to 30 millimeter. That is the point. Okay? Yes, it can be a correct option, but you are going to choose the best option. Okay. So in this case, out of all these 5 options, this is the best option. That you don't have any evidence of intrauterine pregnancy. That is the point. Okay. Is it okay? There is any problem? Anything?
Good.
So E is the correct answer. You all agree, or if you disagree, you have to defend your answer. Okay, E is fine, right? Let's go to question number 18. The incidence of gestational trophoblastic disease in the UK is calculated as, so this here you are simply going to recall the facts. It is 1 in
D.
714.
1 in 714.
Yeah. So do we find any higher incidences anywhere? Tell me which incidence is higher, 1 in 387 or 1 in 752?
ज़्यादा कौन सा है? ये वाला ज़्यादा।
Higher is A, 1 in 287.
So do we see that in UK? No, we don't see
No.
that.
Yeah.
As you know, the incidence of molar pregnancy is higher in some East Asian women, or then the chance is like 1 in 387, and in UK the chance is 1 in 740. Okay, that is the point. So if women of Asian origin, then the incidence is higher. And but they are asking you about the UK, so the answer is 1 in 740. In the previous version of this guideline, they said that 1 in 752, but but now this second guideline is also very old. I think they published in 2010. It gave incidence of 1 in 714. Okay. Question number 19. Which of the following is not an example of gestational trophoblastic disease? Chorioangioma, choriocarcinoma, complete mole, partial mole, or placental site trophoblastic tumor?
Question repeat.
Option A, this one.
Which one of the following is not an example of gestational trophoblastic disease? As you know, if you will go to the basic definition of GTN, it tells you that it is written on the first page of the guideline that it is a group of disorders.
It's A.
Chorioangioma.
Yeah,
Angioma.
because partial
Chorioangioma.
site is GTN.
These others are fine. You know, this chorioangioma, this is a benign neoplasm of the chorionic region, like there are many blood vessels. So by definition, GTD, this is a group of disorders which includes many conditions like complete and partial molar pregnancies, and then it can include malignant conditions. Malignant conditions like invasive mole, choriocarcinoma, and very rare, there can be a placental site trophoblastic tumor. So all of these are possibilities. But if we will talk about chorioangioma, this is a benign neoplasm. Okay. So this can be a congenital new form. Obviously, it can be like seen in the fetus, or it can be seen in the newborn, and it has nothing to do with the GTD. So read the question very well, okay? So question number 20 is, which of the following statements is correct about molar pregnancy? A, complete mole usually 75 to 80% arise as a consequence of dispermic fertilization of an empty ovum. Then B, complete moles, they show evidence of mature fetal red blood cells. Complete moles, okay, pay attention. Partial moles, they occur rarely due to dispermic fertilization of an ovum. Some complete moles, like 20 to 25%, they arise after duplication of a single sperm following fertilization of an empty ovum. 10% of partial moles present tetraploid or mosaic conceptions.
E.
Yeah, this is the correct option. So why did you select that option? Because complete mole.
Complete mole arise as a consequence of a single sperm dividing into two, fertilizing the empty ovum. And
Usually, yeah.
yeah,
Sorry. So in the complete mole, one sperm will enter, and maybe it can, in 75 to 80%, what will happen? There will be a single sperm and single ovum. But then this single sperm, it will divide into two. So basically one sperm is coming, but then it is forming two sperms. So that's why the chromosomal composition will become 46, right? And yeah, what about the next one?
In complete mole, you have empty ovum always, and two options: either one haploid sperm divided into two, or the two haploid sperms uh, fertilize an empty ovum.
Actually, you know, 75 to 50% of they will have single sperm and then fertilization will occur.
But
And
Aisha, these both options actually A and D are correct, but only best their percentage is not any accurate.
yes, that's what I'm going to say. Thank you very much. At 25 to 30 per 20 to 25%, they can have dispermic fertilization. If I will put the number here 20 to 25, then it will be a correct option. Okay, you should write it
Yes.
down. I'm always telling you guys that keep your notebook handy so that you can think about the exceptions. Okay. So 20 to 25% they can have dispermic fertilization, but here the figure is wrong. Otherwise, this is also a correct option. Then complete mole, remember it like this: complete mole is completely devoid of fetal tissue. We don't have fetal RBCs. That's why we do not give anti-D injection to these complete mole patients. Then partial moles, they occur rarely due to dispermic fertilization. Then you know that most of the cases, like almost 90%, they will be triploid. What is the genetic composition of the partial moles? 69, right?
69.
That is the point. Okay, so there are 3
69.
sperms, 90%. Then some complete moles, 20 to 25%, they arise after duplication of a single sperm following fertilization. So here only if we will switch the numbers,
75, 80.
then they are going to be the correct option. So only the numbers are wrong, facts are correct. And then 10% of the partial moles, they will be tetraploid, okay, but they are rare. They can occur. So tell me, if you have a case of molar pregnancy, what will be the ratio of the fetus to the placenta? Any rough idea? So I will ask it in another way. Placenta will be large or the baby will be large?
Placenta will be big.
Placenta.
Yeah,
Yes.
Yeah,
placenta
it's a
will be big.
hydropic change.
Yeah,
Cystic
hydropic
placenta will be
change.
big.
Yes. So placenta will be much larger than the baby. Can be ratio can be 1 to 5. So 1 to 5, 1 to 6. You have to keep these things in mind. All of these are old questions like in strategy, and then they had certain other programs. So they have made many questions, and some of them will be like this. Like if they are asking, they should ask about something more clinical, but sometimes they will ask you such questions. Tell me about any
Dr.
other
Aisha,
condition. Yeah, please go on.
one more question for this complete mole. What is the karyotype? Any because we were confused a few days back in one question. This is for partial. This is 69 XXY or 69 XXX or 69 XYY.
Yeah. So in the complete mole, will anybody like to answer this question?
So complete mole can be 46XY if there is only one sperm, the haploid sperm dividing into two, fertilizing one empty ovum. So the karyotype could be 46XX or XY,
Yes, that's what
depending which
actually,
sperm it has fertilized the empty ovum.
you know, it can be 46X0 also. Okay, there can also be variants. That is the point.
So we will choose the
Interesting
most
situation.
common.
So will you like to? Will anyone like to comment on that? Then I will give my opinion also. So what are the possible combinations of complete mole?
I think it'll be either 46XY or 46XX. I don't know.
Yes.
And then 46X0 also.
You should, it will not be 0, you know, I was just trying to confuse you. It will be either 46XX, that is the most common. And we don't know about the exact numbers, but they can be 46XX or 46XY.
Because 45X0 Turner syndrome. 46X0 not exist. Huh?
46X0 45XO is Turner.
45X0 this is okay, yani Turner syndrome, but yani 46X0 not exist.
46X0 can exist in mosaic form. In mosaic form of the Turner syndrome, you are going to find 46X0, 45X0. And these patients, they will initially have menstruation, like maybe we don't know that for how many cycles, but due to this mosaic pattern, so ovaries will have some reserve. Some reserve with passage of time, that reserve will exhaust and the patient will have premature ovarian insufficiency. So, you know, whenever we are talking about the facts, we are talking that what is happening in the majority of cases, okay? So when we are talking about the molar pregnancy, then, you know, the most likely, most of them, they will have 46XX karyotype and some they will have 46XY. So why we can have these combinations? What is the composition of normal male?
XY.
You have 46 autosome and one sex chromosome, pair one sex chromosome. So that's why it says we have a total number of 40, you know. So
Yes, that's the correct answer, because you will get two haploid numbers, okay?
yeah.
After that, you don't know that one X will divide into two, or one X will remain the same and the Y will divide like that. So you don't know. One sperm was there, and any part of any spermatid, any one thread it divided, and then two conceptions were there. Then you should remember another point about the complete molar pregnancy. This is androgenetic in origin.
Yeah.
Why? Because mother's egg was empty. Empty egg, no genetic material. That is the point. And this is the trophoblastic disease. So the male partner's DNA, yeah, it is forming part of the baby, but from where the placenta is forming. I mean, which genes they will carry the directions for development of placenta? Paternal genes or maternal genes?
Paternal gene.
Paternal genes. They carry all the information on development of the placenta. This is trophoblastic disease. Trophoblast, cytotrophoblast, sensitotrophoblast. The code is in the paternal genes. That is the point. So maternal tissue is not there. No code from the mother is being decoded. So that's why you are getting 46XX or 46XY. And one sperm will be there in 75 to 80% of the cases. And any one of them can divide and give rise to 46XX or 46XY. 46XX is more common. Similarly, for the partial moles, you can get any combinations. 69XYY, then 69XXX or XXY, can be any combination. That is the point. Okay. So important for you to understand the ways of development of the different types.
But more common is 69XXY.
Yeah, most common is XXY, 69, and then regarding the complete mole, the most common combination is 46XX. Okay, so let's go to the next test. So the question number 1 says a woman who is 9 weeks pregnant comes to the early pregnancy assessment unit and complaining of severe nausea and occasional vomiting, and she is not keen on drug therapy. So what is your advice? So will you tell her to take decaffeinated coffee? She should drink ginger syrup. She should drink herbal tea, or she should take a long break from work, or she should take up yoga. What do you think?
B.
What should be?
Ginger
Yeah,
syrup.
Option
B.
B.
Yeah, B is the correct option. She can
Drink
take
ginger
ginger
syrup.
syrup, or she can take any ginger drink like ginger ale, because in many countries in the world, when patient is recovering even from the GA side effects, you know that patient can have vomiting, so they will give them ginger syrup or ginger juice to drink, ginger ale drink. So B is the correct option. Next question, a 33-year-old woman grabbed a 3-para-2, comes to the emergency department complaining of excessive vomiting for the last 3 days. She is otherwise asymptomatic with insignificant past medical history. She is admitted and her thyroid function tests showed a low thyroid stimulating hormone level with raised free thyroxine. So what is the most important feature to differentiate transient hypothyroidism of hyperemesis gravidarum from the hyperthyroidism? So on the basis of which factor you will decide that she is having HEG or she is having hyperthyroidism, like absence of current clinical signs and symptoms of hyperthyroidism, absence of a history of hyperthyroidism, absent enlarged thyroid gland, negative thyroid receptor antibodies titer, normal TSH and T4 in a repeat thyroid function test.
D. Negative thyroid receptor antibodies, because she's not.
So D, right?
Yeah, because she's not actually hypothyroid. It's just beta-hCG is similar to the beta subunit of TSH. That's why she has high T4 levels.
So your patient has, yeah, that is the correct option, D. Look at the question, your patient has low TSH. When they will have low TSH? When the patient has hyperthyroidism, right? What is the most common cause of hyperthyroidism in the women of reproductive age group? Graves' disease. So Graves' disease, what sort of disorder is Graves' disease?
Autoimmune?
What type of disorder is Graves' disease? Autoimmune disorder, right?
Yeah.
So in autoimmune disorders, yeah. In autoimmune disorders, we are developing antibodies against our own tissues. So they know antibodies. That is the problem. Okay. So D is the correct option. For the first question you have written that what is the correct answer? It was B, right? First question's answer is B, and second question the answer is D. Let's do question number 3. Okay. A primary gravida who is 10 weeks pregnant is complaining of slight vaginal bleeding and the occasional abdominal colic. Ultrasound shows a live singleton pregnancy corresponding to her menstrual period, her LMP, and she is worried about losing this pregnancy and asks for any medication to help keep the pregnancy. She has read something about progesterone treatment. How will you counsel her? So she is 10 weeks. Sometimes she has cramps and sometimes she has slight bleeding. That she can start oral progesterone therapy, or she can start a combination of oral and vaginal progesterone as it is more effective than single therapy. She should start a combination therapy if she gets severe colic. There is no strong evidence to recommend the use of any progesterone therapy. Vaginal progesterone is more effective to treat threatened miscarriage. So
D.
Option D.
yeah, option D.
Strong evidence.
So actually this is abuse of progesterone that we give to all cases of threatened miscarriage. No proven benefits, okay? And where it is going to help? There must be some rationale for offering this treatment. So who is going to benefit?
In IVF pregnancies, they give progesterone.
Yes. Why IVF pregnancies?
Because they get all they get ovarian picking up the oocyte retrieval. So you drain all the follicles and you deplete the follicles from progesterone. So they need replacement therapy for progesterone. And for people with low fertility, they are given supplement of progesterone to keep the pregnancy going at least for 8 to 12
Luteal deficiency.
Yeah. So you can say that if there is evidence of benefit of administering progesterone only in the high risk group, not for everyone, but in the high risk group, you can give this medicine. Okay. So there is some evidence that it is helpful, but only in the high risk group, and generally there is no benefit, so it should not be given to everyone. And if you have to give progesterone support, like patient has a bad history, then you should give it only for 8 weeks. After that, placenta starts functioning well, so you don't have to supplement it from outside. Okay. Question number 4. A 20-year-old woman who was 9 weeks into her first pregnancy, she has just had a complete miscarriage. She is distressed and very tearful. Who have explained that miscarriage doesn't affect her future fertility. Her partner is worried that her anxiety may persist and be possible cause of a delayed pregnancy. What else will you tell her? What else you will tell them? That her anxiety will go away when she misses her next period. Her anxiety will persist until she achieves another pregnancy. Her anxiety will continue until she has a healthy baby. Her anxiety will most likely disappear in around 4 months when she gets over it. Then she should be referred to a psychiatrist. So if he is tearful, so is that a normal feeling after a miscarriage, or it is abnormal?
normal.
It is normal. So should we refer all such people to the psychiatrist?
She needs counseling more than a psychiatrist, actually, because sometimes people after miscarriage are sent to the for counseling. So not psychiatrist. I don't know the answer anyway.
Anyone else would like to say something?
I think so. It's D. Her anxiety will likely to disappear in 4 months when she gets pregnant. Over it.
No,
Yeah. Because you will give her some time for resolution of the grief reaction. So if you will go to the psychiatric help, then you must have seen that they are putting more emphasis on self-help strategies. Just a little bit of counseling, and then if the patient doesn't improve with self-help therapies, then you will have to refer her. Why this is the case? Why can't we send her to the psychiatrist right now?
Because she's not pathologically like she doesn't have pathology. She's not a chronic depression. She's not suffering from chronic depression. There's an event, and she is, as a consequence of that event, she's fearful.
Yeah, because right now she's just having a reaction which is quite normal, and they have given her age like she's a teenager, but in any age person can experience difficulties. So you give her some time for resolution of the grief, and if it doesn't go away, then of course you will have to refer her to the psychiatrist. And then going to the psychiatrist, in many cultures it is taken as a taboo, like what the people will say, this is a social labeling. So her reaction is quite normal, and we anticipate this sort of reaction. So you will give her some time, and you will tell her that if the symptoms persist, then she will need further help. Question number 5. Woman who is 11 plus 3 weeks pregnant complained of abdominal colic and an attack of raised vaginal bleeding. A repeat ultrasound confirmed fetal demise. She diagnosed inevitable miscarriage, and she is considering expectant management. How will you counsel her? So she has she is symptomatic, okay, and she has brisk vaginal bleeding and episode. So we will the options given are arrange for expectant management in a hospital setting as she is under a high risk of bleeding. B, agree that the expectant management is her best option. C, explain that she is at a higher risk of bleeding. D, recommend surgical management as she is at a higher risk of bleeding. And wait for 14 days before you recommend other options.
C, explain that she is at higher risk.
Yeah. Because C is the correct option, because as a clinician you have to be truthful and you have to give your sincere advice. So regarding this expectant management in hospital setting, it doesn't happen. And we cannot wait for 14 days in her case, because she may have excessive bleeding and she may go into shock, and we don't know what sort of social support is available for her. So just explain truthfully that she's at risk of having heavy bleeding. So it will be better for her to go for a certain treatment, which will be a surgical management in this case. They didn't
There's
mention
another,
yeah, go on please.
Sorry, I'm sorry.
No, that's fine.
The stamp D. I was a little bit tempted for this answer as well, because it says recommend surgical management as she is at higher risk of bleeding. More, but then I picked the C.
We cannot recommend, we can counsel her. So the question is, how will you counsel her? So we will only tell her that there is a risk of high risk for bleeding.
Okay.
The rest goes with the patient.
Yeah, I will agree with her. Yeah, I will agree with her, because the question is categorically asking you that how you will counsel her. So you will tell her that she is at a high risk of bleeding, and then you will expand that a little bit, that in view of this high risk, I will suggest that you will have heavy bleeding, so we should go for the treatment now. We should remove the tissue. That is the point. Okay. So you are going to tell her about all options on the table, whatever is available to her, and then you will further expand on that. So in the first line, you are going to tell her that you know that you are at risk of having this problem. You have to tell her that what is her status and what can happen to her. Then you are going to tell her about all suitable options for her in this case. Then you will tell her about the benefits and the side effects of all interventions, what is the intended benefit, and what alternatives she has. So you are going to talk about everything, but initially you are going to open up. The opening sentence will be that she is at a high risk of bleeding. That is the point. So why you will not recommend anything? You will, whenever you are seeing a patient.
In counseling, we will give her the options. We will counsel her. We will tell her the complications and what can happen, or what, and for that what can be done. So,
so if you see a patient, do you try to assess their mental capacity, or you will just give the same information to everyone?
of course, the mental capacity
No,
we will assess
we will
that.
check the IQ of the patient.
Yeah, IQ of the patient. Actually, IQ and the mental capacity, they overlap. Why? Because if the patient has come to you, it means that she knows that what is going on, what is happening to her. She can understand that she is in trouble, right? Otherwise, she will never come to you. Then, if she is listening to your information, and then she's thinking, and then she's conveying back her, this answer or her own opinion to you, and she's understanding that what are the consequences of her specific choice, then she's exhibiting mental capacity. The law says that when the patient comes to you, you will say that she has mental capacity unless proven otherwise. Like you have the history, or the patient is not responding in an appropriate way, like she is obviously she is not listening to anything. she's not understanding, she has no clue, she's being cared by someone, or she has some compromise of the mental activity, mental faculty, then you have to think that maybe this patient is not having this mental capacity. So, and then you have to assess mental capacity at each visit. You will never say that 5 years ago she was competent, so we don't know what she has gone through in the last 5 years. Maybe her thinking has changed. So you are going to assess indirectly. You are not asking her the questions. This is your judgment that this patient is fulfilling all parameters of the mental capacity. So that is the point. Okay. So in that case, and then you will give the patient the right to choice. This is also called respect of the patient, or respect for the wishes of the woman, or autonomy. Even if she's making a wrong decision, we are going to tell her that what problem she is getting into, and that's it. Okay. If sometimes the patient doesn't have mental capacity, then you will have to decide, and then what you will have to decide for her. So what do we call that principle? That will be justice or beneficence. That will be beneficence, because you have someone who cannot decide for herself, or the family cannot decide, so then you are helping them and you are giving them the best possible option. The judgment means that if you are recommending a treatment for a certain patient, it means that you have evaluated the case well, and then after thinking about that, you have reached this conclusion that my patient has problem A and solution B is the best available option. Okay, so you have to justify whatever you are doing, why you are doing, what is the benefit for the patient, and what will happen if you will not do that. So that will be justice. And beneficence is when you are keeping the needs of the patient in front of you and in front of yours, and you are giving her the maximum benefit. That's how you can differentiate between the principles of beneficence and judgment and justice. Okay. So C, C is the correct option. We are just going to tell her that she is in trouble, and then in the next step we will tell her that how we can go out of trouble. So question number 6, a woman who is 11 weeks pregnant with confirmed miscarriage, she was very hesitant in deciding on medical or surgical management. She was still keen on avoiding the anesthetic and the surgical risks if possible. What will you tell her about chances of not having surgery if she opts for the medical management? Like A, it avoids the need for surgery in over 30% of women. B, it avoids the need for surgery in over 40% of women. Then C, it avoids the need for surgery in over 50% of women. D, it avoids the need for surgery in over 60% of women. So E, it avoids the need for a surgery in over 70% of women. To put this question into simple words, they are asking you about the success rate of surgery. What is the success rate of medical management? Or what is the failure rate of the medical treatment? So you need to recall your information, that what is the success rate of medical treatment. So in what percentage of patients medical management is going to be successful?
60%.
Yes, 60% is the correct answer here. We cannot say that it is 70%. It is between 60 to 70%. Okay, that is the point. So then what will happen to the remaining patients?
B होगा, it avoids the need for surgery. 40%.
You know, if you will go to the FIGO information, it will say that the effectiveness, that the medical treatment can be successful in 85% of the cases, but then they are not giving you just one number, right? In some studies, they will say that if you are giving misoprostol, then the success rate is going to be like 98%. So that is the success rate of the misoprostol if you're using a specific drug. But then you have to think about other variations, that it is not only about the drugs, it is the response of the patient to the drug and other underlying factors which we know nothing about. Sometimes these patients who are taking medical treatment, they will develop some complication, like they will start having this bleeding. The rate of infection is very low, but the rate of bleeding can be up to 10%. Rate of infection can be 1 to 2%. So in that case, you will have to go for surgical management. Okay? Not necessary that the medical treatment has failed. Medical treatment was going on, but suddenly your patient has developed abdominal pain or bleeding. Then you have no other option. Then you will have to go for surgical management. So D is the correct answer. The problem with the RCOG is that they will not give you exact figures. Like they have mentioned in their book, they will give you a range. So in that case, you should not go towards the lower number. If you are in doubt, go towards the higher number. What is the magnitude of the problem? Go for the higher number. What is the success rate of a treatment? Don't go for the higher number, go for the lower number. Because as I have told you that the medical literature says that the success rate of medical treatment can be 98%, can be 99%. So that is only about the medical treatment. But the patient, if she has some other problems, then there is a problem.
So
Question number
correct
7.
answer is B.
D.
Okay.
Question number 7. A 20-year-old woman comes to the early pregnancy assessment unit with 7 weeks and 6 days amenorrhea and mild to moderate vaginal bleeding with the occasional abdominal pain. She has a positive pregnancy test but refuses a transvaginal ultrasound. How will you handle the situation? So A, you will ask the consultant to talk to her. B, ask her to sign a form that she refused medical advice. C, refer her to the radiology department for a scan in the earliest available appointment. D, respect her wishes but explain the limitations of transabdominal versus
D.
transvaginal scan.
D.
Yes, this one.
Yeah, D is, and then send her
Option
back
D.
to her GP. So D is the correct option. So you will tell her that what benefit she is getting and what problems she can have. That is the question number 8. A woman who is 8 weeks pregnant complains of vaginal bleeding. Ultrasound scan shows a CRL of 7 millimeter, but no visible fetal heartbeat. So you advised her to come for a follow-up scan after 7 days, and she expressed concerns that waiting that long may harm the pregnancy or her health. How will you counter her concerns? A, assure her that waiting for a repeat scan will have no detrimental effect on the outcome of the pregnancy or her health. B, ask the midwife to talk to her and explain the unit's regulations. C, explain that a serum Beta-hCG measurement will confirm the diagnosis of fetal demise. D, give her a leaflet explaining the unit's procedure. E, offer her termination of the pregnancy as this is most likely non-viable pregnancy. So she is 8 weeks and she has bleeding and CRL is 7 millimeter but no fetal heartbeat. And you told her to come back and she is showing the concern that if she will wait for a week, then the baby may develop some problem or she can develop some problem.
A.
Yeah. Yes,
Yes,
D is the
option
correct
A.
option. Yeah. Patient is stable, so it is not going to affect her. So, this is a matter of simply following the guideline and common sense that patient is fine. She has no risk factors in her history, so you can explain to her. But you will explain with the help of the guidelines, with the patient information leaflets. They are made so that you can counsel the patient appropriately. Question number 9. The community midwife calls you about an 8-week pregnant woman who is complaining of vaginal bleeding and abdominal colic. A repeat scan confirmed fetal demise. She opted for expectant management. Her bleeding and abdominal pain has resolved. The woman wants to know how to confirm that miscarriage is complete. So what will be your advice? A. No need for any further follow-up as she is no longer symptomatic. B. Return for advice if the bleeding starts again. C. Repeat a pregnancy test after 1 week. D. Repeat a pregnancy test after 2 weeks. E. Repeat a pregnancy test after 3 weeks.
E.
Then E, repeat a pregnancy test after 3 weeks.
Yeah, it should be done. E is the correct answer. Actually, should be done after 3 weeks, but in this patient, what type of management? Expectant management. So you have carried out the expectant management, so you should do this test after 3 weeks. The guideline clearly mentioned it. Okay, so the answer is E. Next question is, a woman is 11 weeks pregnant, diagnosed with incomplete miscarriage. She opts for medical treatment. So what will you offer her? She is diagnosed with incomplete miscarriage. What sort of miscarriage she has? Incomplete. Oral mifepristone and 800 microgram misoprostol in one setting, then oral mifepristone and then 800 microgram misoprostol when he starts having contractions. Oral 800 microgram misoprostol or vaginal 600 microgram misoprostol or vaginal 800 microgram misoprostol. So you know the recommendation is that in incomplete miscarriage you have to give 600 micrograms misoprostol. That is D is the correct answer. Question number 11. A pregnant woman is diagnosed with miscarriage based on the absent cardiac pulsations in repeat scan. She opted for surgical management as her work commitment would not allow for a long wait and she feels she may not be able to cope with bleeding and pain if she opts for medical management. She was undecided, however, about an outpatient setting, manual vacuum aspiration under a local anesthetic or a hospital evacuation under a GA. How will you counsel her? A. Arrange for a meeting with an experienced counselor. B. Ask the consultant to come and talk to her. C. Explain that the median waiting time, the number of the women requiring a blood transfusion, and the mean blood loss, they were all lower in a outpatient setting. D. Strongly recommend MVA because she will not be exposed to the risk of general anesthesia. E. Strongly recommend EVA because it is more effective.
Option C, I think.
Yeah, it's a case of, diagnosed case of miscarriage and she wants to have this surgical management. Then we know that if it is done in the outpatient setting, then it is associated with lower rate of complications. And here in the question, one information is missing, that this woman is nulliparous or she is multiparous. Because multiparous, then the success rate of manual vacuum aspiration is higher and the rate of other interventions will be low. But if she is nulliparous, then maybe your options, they will change. So, but out of all of these options, this is based on the facts, okay? So we can do that. C. Question number 12 says, a 23-year-old woman in her second pregnancy presents to you requesting surgical termination of the pregnancy. She is 11 weeks pregnant, verified by ultrasound scan. So what is the risk of uterine perforation in this case? So you know that the rate of perforation in the surgical termination, what is the rate according to the new consent guideline on surgical management of miscarriage?
Option
Still it is 1 to 4 in 1000.
A.
Yeah, A is the correct option. Okay. Question number 13. A 31-year-old woman is booked for surgical termination of pregnancy at 9 weeks gestation. Which of the following options is correct regarding prevention of infective complications? You should give augmentin Okay, first of all, tell me, does she fall in the high risk group? This 31-year-old woman. Okay, and think about it. Okay, augmentin 625 milligram within 2 hours before the procedure, then ceftriaxone 500 mg within 2 hours before the procedure, or doxycycline 200 milligram within 2 hours before the procedure, or metronidazole 500 mg within 2 hours before the procedure, or no antibiotics are needed. So basically the question is that should we give antibiotics in this age group?
No.
So who should be getting antibiotics?
25 and less.
Yeah, 25 and less. So she doesn't need antibiotics. In a neat and clean case, you don't have to give any antibiotics. So if you have to give it to a younger patient, like she is 25 or less, then what will you like to give her? Something with a broader coverage, right? Various combinations can be given. Yeah. What should be given?
Doxycycline.
Yeah, doxycycline can be given. Actually, if you are treating doxy, you are giving for chlamydia, right? So you can give different combinations. Mostly you will give them something to cover both gonorrhea and chlamydia. Why gonorrhea and chlamydia? Because chlamydia is responsible for 30% cases of PID, and gonorrhea like 5 to 10%. So these two are the two most common causes. Okay, so if you have to choose one, I'll go for doxy because chlamydial problems, they are the most common. So with this woman, she's 31 and she doesn't need any antibiotics. Question number 14, the general practitioner calls you out of hours to ask what to do because she has an 8-week pregnant woman who is complaining of moderate right abdominal pain and slight vaginal bleeding. So what is your advice? A, book the woman on to the earliest ANC appointment. B, book the woman for the earliest possible ultrasound scan. C, immediate referral to the emergency gynecology unit. D, offer the woman an analgesic. And E, refer the patient to the next day early pregnancy assessment unit. Now you should keep one thing in your mind, that the patients who have some complications, the ultrasound is not always accessible. Okay, in some units you will not even find the ultrasound machine, so you will have to refer her somewhere. And on average, the patient will wait for like 24 hours. But tell me about this one, that she has slight bleeding, but she has moderate abdominal pain. So what should be done for her?
Refer the patient to the next.
So what will be the option? C or what?
E.
But she has moderate right abdominal pain. Eight weeks. So think about the complications you can have at 8 weeks of pregnancy. So pain and bleeding. This one has just slight bleeding, but she has moderate pain. So if she's the first trimester and she has pain on the right side, right? She is pregnant, but if she has pain on the right side, what are the possibilities?
Immediate referral to the emergency gynae unit.
She should go to the ER. So if I ask you that, is it possible that she is having appendicitis? Can she develop appendicitis during pregnancy? Here they are telling you that she has pain on the right side of the tummy, and this is moderate, and there is no other associated figure. No numbers have been given. Okay, so if we think about the incidence of this appendicitis, it is suspected in 1 in 800 and confirmed in 1 in 800 to 1 in 1500. Signs and symptoms, they can be specific, they can be non-specific. Okay? And the problem is that if you will exclude, if this patient will go for ultrasound, what should be, if he is having appendicitis, what they will see is that there is a tubular structure on the right side of the pregnant uterus, which is non-compressible. So they will diagnose on the TVS, and then they will say such things. So if they will do the examination and they exclude appendicitis, it will be good for the safety of the patient. Okay. The problem with the appendix can be that it can burst. So on ultrasound, you are going to see simply a non-compressible structure, which will be like 10, can be 8 to 10 centimeter long, and the diameter will be more than 6 millimeter. So simple TVS is going to discriminate that she is having pregnancy associated problems or she is having some problem because of the appendicitis. The problems with the appendicitis are that if sometimes if the patient has like if it bursts, then it will cause generalized peritonitis. Okay, and it will have its own mortality rate also. And chance of perforation of the appendix is not low. It is as high as 36%, which is significant. Okay. And maybe she's having ectopic pregnancy, because slight bleeding, it should raise your suspicion. So we don't know exactly that she is having appendicitis, she is having an ectopic pregnancy, because they didn't tell that where exactly is the pregnancy. We have no comment. So it is better that we should get the ultrasound done. It may be an ectopic pregnancy. It can be a case of appendicitis. So if you cannot reach a decision, then you should take care. You should not wait till the next day, because in 80% of the patients who are having appendicitis, there will be subclinical inflammation. And if the patient has severe tenderness, then you should do the surgery, and you have opened the patient in the first trimester. You know that you can do this laparoscopically. So even if you have found that the appendix is healthy, but now you have opened, so remove the appendix and restore hemostasis. And then on histopathological examination, you will find evidence of inflammation. Okay. So let this patient go to the ER and let them decide for her that she is having any ectopic pregnancy or she has some other problem. Your patient has you have two clues here. She has slight bleeding. So ectopic pregnancy, your patient may present with slight bleeding at the time of periods, or she can have a brownish discharge, and the pregnancy test will be positive. Then it will you should think about the ectopic. And moderate pain, even if they will tell you that she has a mild pain, if mild pain, then you can give her some painkiller and then wait for like 2-3 hours, and then ask the patient if is she feeling any better. If she's feeling well, okay, fine. If she's not, then we will send her for further assessment. But this one has moderate pain, so if you will give her to mark on a 1 to 10 scale, at 1 no pain and 10 more pain, so moderate pain means that she will score anywhere between 4 to 7. So let this patient go to the ER. They will do a simple ultrasound. They can distinguish between the two clinical conditions, and then they can take a decision on. Okay. Question number 15. The midwife in the early pregnancy assessment unit asked you to review a woman who has 7 weeks of amenorrhea, but the previous and current ultrasound couldn't locate the pregnancy. The human chorionic gonadotropin increased from 800 to 1600 after 48 hours, and the woman is fit and well with no signs or symptoms. So what is the next plan? Ultrasound within 4 to 7 days. B. Ultrasound scan after 14 days. C. Ultrasound scan after 9 days. D. Request an inhibin blood test. E. Request a serum progesterone blood test. So some of the options, they will be clearly wrong, like these 3 options are totally wrong. So what will you like to do for her? So first pay attention to this one.
Okay.
Yeah. But it has doubled. Simply from 800, it has gone to 1600. That is the point.
Yes, option A.
Yes, you will ask, but here is one catch. In 4 days, do you anticipate to see any change?
1500 it should be intrauterine.
Okay, yeah, that is the answer, but they didn't give us that option. Okay, so I will agree. A is the correct option for me. At this 1600, at 1600, you should be able to locate a pregnancy by transvaginal scan. So here they didn't tell you that what sort of scan they have carried out. Okay, so it's your chance to do the scanning within 4 to 7 days, because now you will do transvaginal scan. Then the second thing is that initially they couldn't locate a pregnancy, but now the serum beta-hCG has doubled. It has gone from 800 to 1600. So the rise is fine. So still you should carry out the test. And the woman has no signs and symptoms, but you should locate the pregnancy. If you will wait for 14 days, then it is too long. And you should remember that 1/3 of the ectopic pregnancies, they will be totally asymptomatic. Okay. So just to exclude the ectopic pregnancy, you should carry out this ultrasound within 4 to 7 days. We will not assume that this patient has no problems, so she is going to be fine. She doesn't have any problem now, but what will happen tomorrow, we don't. Okay. So A is the correct answer. Let's go to the next question. This is not final. Maybe when you will be revising the answers, you will find that we didn't answer it correctly. So we can always share our opinion. Okay. Question 16. The serum beta-hCG of a symptomless or asymptomatic woman with a pregnancy of unknown location has dropped by more than 50% after 48 hours. So what is the next step you will advise? A. Ask her to submit a urine pregnancy test after 14 days if she stays asymptomatic. B. Discharge her home. C. Repeat serum beta-hCG after another 48 hours. D. Request a cancer antigen CA-125 blood test. E. Repeat a Doppler ultrasound scan. So like I said, that 2 or 3 of the options will be totally wrong. Just eliminate them. Leave these 3 options. So what should be done? Her serum beta-hCG has dropped by more than 50% after 48 hours.
Option
A.
A.
That is, she's asymptomatic, so she can have the UPT after 14 days.
Yes, she's asymptomatic, so she will not be repeating it after like 48 hours. So what should be done? If you will wait for 14 days, if she stays asymptomatic, so after 14 days, what will you like to do? Urine pregnancy test, if you have to do, you will do it after 3 weeks. So again, that is wrong. And should we discharge her, or should we repeat the beta-hCG after another 48 hours? When you have a patient with ectopic pregnancy, then you should take at least 2 readings before making a decision on her. So is this question complete for you? I think this patient has already given samples twice, because otherwise you will not know that what was the baseline level. Okay? no symptoms and nothing, and it has dropped by 50%. So this woman can be discharged, and the guideline says that now you can discharge her, but after 1 week you will need to repeat it. So this option A is obviously wrong, and you don't have to repeat after another 48 hours because you already have two samples. CA-125 has no role, and request Doppler ultrasound, it is not beneficial. So can we discharge her? So if anyone has dropped this serum beta-hCG by 50%,
I
do
think
we
so.
leave
Then
her,
we can discharge her.
or we will repeat the serum beta-hCG?
Serum beta-hCG, yeah.
Yeah,
After 1 week.
should be done after 1 week, but if they didn't give you that option, then what you will do? Now you have to choose between the two facts. That should you discharge her, or you should repeat her scan, or you should repeat the serum beta-hCG.
Then option B is better.
But the problem is that
Then we will have to do the beta-hCG after 48 hours. That is
yes,
much more better.
yes,
Because in
because
order to discharge her, we will not be having a follow-up visit of her.
yes, if you,
So we don't know that the beta-hCG will further fall or not. So we have to
yeah,
see it. So that's it's C that we have to repeat beta-hCG for another 48 hours.
yeah, I will go with repeat serum beta-hCG after another 48 hours because I cannot see any numbers here. I don't know what do they mean by 50%. Maybe it was 2,000, maybe it was 5,000 international units to begin with. And as you know, the cases of rupture, they have been reported in medical literature even at 20 international units of beta-hCG. So if we will discharge her, then it means that you are just leaving that patient. If they will tell you that let this patient go home and repeat serum beta-hCG after some time, then I will know that I will not lose this patient to follow up, right? So you should remember that in the SBAs and even in the EMQs, you will not find the perfect options you are looking for. Okay, here you must be looking for something that maybe we can test her after a week or so, but it is not here. So choose the next or the second best possible option. Okay, I will not discharge her because my guideline says that we should follow up this patient till her serum beta-hCG drops to 20 international units. That's why, though you won't agree with this option, but you should do another serum beta-hCG after 48 hours. That is the point. Okay. So go for C. So choose the most suitable option out of the options available to you. Okay. That's why, you know, even after answering many questions to the best of your judgment, you will not feel very happy because you will ideally you will like to be more specific and you will look for a better option, but that is not given. They have put five limits that you are going to choose just one of the 5 options. Okay? And these are not short answer questions. That's why you will choose the best possible of the best of the all available options and move on. Okay. If you're not happy about your answer in the actual exam, when against that question, just put a question mark or write down that check it later. Okay, but don't leave that answer that place on the answer sheet blind, because then if you will make a mistake here, like by entering answer of another question, then you are going to continue making the mistake. Okay, so just click or just slightly cross that number and cross that option like A, B, D, whatever you like, and but write down on your answer sheet that you are not happy about that answer and you would like to come back later and do that. Okay, make it a habit. Okay, question number 17. A woman who is 8 weeks pregnant and she is offered laparoscopic surgical management of an ectopic pregnancy. She had a previous normal pregnancy and vaginal delivery. How will you justify laparoscopic salpingectomy as opposed to salpingotomy? 8 weeks and she has an ectopic pregnancy. Previously, she has a normal delivery. So how you will justify self-injectomy as compared to self-ingostomy? So removing the disease tube is easier and quicker to perform. Then now you're counseling her, okay? B, removal of the disease tube will not affect her future fertility. Removing the ectopic pregnancy and keeping the tube will have a significantly higher incidence of a recurrent ectopic pregnancy requiring repeat surgery. D, removing the ectopic pregnancy and keeping the tube will require more follow-up visits and tests currently. Then there are no differences in the management options for the current or future pregnancies. So why you will like to do self-injectomy? Because if she has an ectopic pregnancy, she has 10% chance of getting another ectopic pregnancy. And in most of the cases, that ectopic pregnancy will occur in the same tube again. Okay, so you should go for self-injectomy.
Option C.
Yeah, C is the best answer here, so we will stick to that. Okay. Question number 18. A 15-year-old single teenage girl comes to you to see you because she had an unplanned pregnancy and she is 9 weeks pregnant after failure of an emergency postpartum contraception. She explains her great inability to handle either the pregnancy care or the child, and if born, then for personal and social reasons. So how you will handle the situation? A, ask her to bring her parents to discuss the situation. Then ask her to bring her boyfriend to discuss the situation. C, advise her to involve her parents but endorse her request if two doctors agree that she has sufficient maturity and understanding to appreciate what is involved. D, refer her to a psychiatrist to assess her ability to understand what is involved. E, she cannot have an abortion without her parents' consent because she is under age 16. So what do you think? What is the correct option? Capacity or she doesn't have it? She is evaluating her condition, right? That what will be the personal and the social effects on her life. So she has the mental capacity. And just to sign the consent form for the termination of pregnancy, you need signatures of two doctors. So C is the correct one. Refer her and so that she will get the, because she merits, and the Fraser guideline says that it is applied to two conditions: provision of contraception and then termination of pregnancy. If she is competent, she has the right to choose her future options, her options here. So just comply with her wishes, so you don't have to tell anyone. Why you are advising her? Because she should keep the parents in picture. So as a doctor, actually this word advise is wrong. They should have used the word encourage. Rest of the options are wrong. Question 19. The GP calls to ask about the immediate follow-up of a woman who had a suction evacuation of a complete molar pregnancy. So what is your advice? A, do a urine or blood test for HCG every 2 weeks for 8 weeks. B, do a UPT every 2 weeks for 24 weeks. C, do a urine check test every week until it is negative for 4 successive tests. D, do a urine or blood test for HCG every week until it normalizes. E, no need for any follow-up if the urine pregnancy test is negative after 1 month.
Option B.
What you will do for 24 weeks, and urine pregnancy test, how it will help you.
I think so. It's E. Because if she doesn't need any follow-up, if the urine pregnancy test is negative after 1 month, the time frame is of 56 days. So if it is negative, so
Then the question is that if you recall, then if someone had a molar pregnancy, do we have to book them for a follow-up? Do we have to register them with any center?
Yes.
yes,
Yeah. And for how long we continue to monitor them?
we will do the HCG levels. If it falls like quite well within 56 days, so till the time it got negative from the day of evacuation. And if it doesn't fall, so we will take the days from the normalization of HCG. But I'm pretty much confused that how often.
For 6 months?
For 6 months?
6 months. I think these are right.
Do a urine pregnancy test every 2 weeks for 24 weeks. So, but tell me one thing, what information you will get from the urine pregnancy test? It will be positive even if there are 5 international units. So basically, if you are doing an intervention, then you're trying to achieve something. So what is the purpose of follow-up in this patient?
To monitor beta-hCG. Yes,
To
should
monitor
not be
beta-hCG.
UPT.
So it will not be anything to do with the urine, okay? And so actually, if we will talk about the serum beta-hCG level, we have to monitor it till it will reach 0, right? And regarding that rule of 56 days, it was for the patient when they will ask you about using any form of contraception or when they want to try again for conception. Okay, that is the point. So first of all, you have to tell the couple to use effective contraception. Then you have to follow the patient up till her serum beta-hCG normalizes. Normal serum beta-hCG will be less than 2 international units. So when you are saying E, so E is totally unacceptable because it is normalizing after 1 month. So urine or blood test for HCG every week until it normalizes. So actually we have to do the test on weekly basis, but urine has no role. We have to do that in the serum. Then do a urine check test every week until it is negative for 4 successive tests. Then do a pregnancy test every 2 weeks for 24 weeks. And then do a urine blood test for HCG every 2 weeks for 8 weeks. Normally what happens is that you are going to check on weekly basis, and when it will normalize, it depends upon the individual response of the woman. So but you know that you have to see that what is the serum beta-hCG level after evacuation. Has it returned to normal or not? Usually it will return to normal within 8 weeks. Okay? If it doesn't return to normal, then you will continue following her up, and you will go till the time it will come to the normal limit. So if you will look at the options, then none of them is very specific, because all of them are checking like urine and the blood, urine or the blood.
Doctor, but option D, right, urine or blood for HCG?
Yes, because he is giving you the option of, because the method is that we have to do it every week. Okay, that is the point. We don't do it every 2 weeks because you have to answer in the light of the practice which is done most frequently. Like I said, that what do we do most frequently? So out of all of these options, D1, and this one seems the best out of these four. But still, I'm also not very happy with this answer because we don't do any urine test for it. We will just go for the blood test. That is the point. Anyhow, think about it, but till we meet next, I will keep this option as the D, because out of all these five, the D1, it seems the best. So think over it, and if you find something different, then please let me know also, and I will also check it again. That because all of these options are not suitable, but in the exam you are going to get options like this. So in the existing options, D is the best out of all these five